And I should also announce to any attendees that this welcome to the Lunch and Learn session. This Lunch and Learn session will be recorded. If you're not comfortable with attending a recorded session, please feel free to leave at this time, and we can certainly send you a recording of the session. But by staying in the room, that is giving permission to be recorded. Thank you.
So Beth and Paul, I think I'll wait until I have 11:58. I'll wait until it's officially noon and then start with an introduction, and then we'll expect folks to roll in.
That sounds great, Robin. Thank you.
Thank you. Okay. I have noon o'clock. Great. Welcome to those who've joined, and I anticipate we'll have folks join as we kick off. I'm super excited to get started with our second monthly Lunch and Learn session sponsored by the Patricia A. Tietjen MD Teaching Academy. We are so thankful for this opportunity to connect with folks across the organization and to sponsor these hour-long opportunities to think and hear and chat about topics of interest to our clinical educators. We are super excited today to welcome Dr. Paul DeChant. Dr. DeChant is the expert on physician burnout. He has thought about it, studied it, written about burnout. He has experience as a physician and as an organizational leader, and is currently working with our organization to help us navigate challenges and opportunities with regard to physician burnout. He's also just a really lovely individual. He comes from such an inspiring and authentic place. I know we'll all really enjoy the opportunity to connect with him. So I'm going to turn it over to Dr. DeChant.
Great. Well, thanks so much, Robin, for that very nice introduction. And I am going to start sharing my screen and make sure that what you are seeing is the right thing. Are you seeing the title slide here, Understanding Burnout for the Clinical Educator?
Yes.
Okay, great, great. So I just want to thank everybody for being here this afternoon. I know you all have very busy schedules. There's a lot going on. And I appreciate your taking the time out to explore this topic with me here. The objectives for this hour are to help you gain a deeper understanding of what really drives burnout and what the manifestations of burnout are, and then apply principles of professional fulfillment in your role as a clinical educator. In this process, I first want to just step back and say thank you for being clinical educators. This is such an important role to help develop the workforce that's going to be coming in the future to take care of all of us as we age. And I'm going through that process myself right now. because we are all facing these challenges of burnout, the more that you can be that positive role model and help the learners that you're working with to understand what they can do to make their career fulfilling, the better off we'll all be. So I really appreciate the work that you're doing and hope that this will help provide some additional support to that work. Let's get right into it. The problem here with burnout is not the clinician. The problem with burnout is the workplace. It's not the worker. In fact, we know that clinicians are some of the most resilient people on the planet. You can't get into medical school without getting through organic chemistry, which in and of itself takes resilience, but then getting through medical school, getting through residency, getting established, and just getting through every day takes tremendous personal resilience. The problem is not a lack of individual resilience. The problem is the workplace itself. Now, what we're aiming for is professional fulfillment. It's actually being in work that is meaningful. And that gives us that reason why we went into this profession to start with. The kind of things where we, as clinicians, can deeply engage with our patients. Those moments give us deep professional fulfillment. For people who do procedures, being able to focus on and do that life-altering or life-saving procedure definitely provides professional fulfillment. For educators, working with learners as they're coming into our clinical workforce and helping them to be the best that they can be, again, provides good professional fulfillment, as does for those people who are interested in research or innovation, changing and improving the way that healthcare is delivered. All of these activities provide us professional fulfillment. The challenge is that we get to spend about 1/3 of our time actually deeply focused on these activities, and about 2/3 of our time gets caught up in administrivia and data entry and other things that really distract us from what provides us meaning in our professional lives. Just imagine the potential if we could just flip that ratio and spend 2/3 of our time doing things that are truly meaningful and 1/3 of our time perhaps doing the administrivia and data entry that's required in order to have that meaningful time. There's just so much opportunity here if we can grasp it. What happens in burnout, and burnout actually now has been defined in ICD-11 as an issue. It's an occupational phenomenon. This is not pure depression from someone's life situation. This is really related to occupation. And it has 3 dimensions. Most people are pretty aware of these by now. Exhaustion, the first one. And I think of exhaustion as meaning I've given everything I've got. I have nothing left to give. I am really depleted. When I get to that point, then you start to develop a self-protective mechanism that shows up as depersonalization. Much more commonly, we think of that as cynicism. It's a self-protective mechanism. I'm protecting myself from my organization or from my patients because I've got so little reserve, I really have nothing left to give. And when those two come together, you can create this sense of inefficacy, like what I'm doing really isn't making a difference. And in many ways, I think that's the saddest of all, because in almost every patient encounter or encounter with a learner, the person on the other end of that encounter is finding value in that interaction. And yet the burned out clinician may well not be feeling that same value in that very same interaction as the other person that you're engaged with. I've had the great pleasure to get to know Christina Maslow, who developed these dimensions. What she's also done is explain the drivers of burnout that lead to those dimensions. And the first driver is work overload. No big surprise to most of us. We work in chaotic, time-pressured environments where there's information overload as well. When we get caught up in that level of challenge, what often happens is we feel as though we're losing control. And there's many factors that are driving a loss of control that we'll present and talk about a little later in the presentation here. But control is actually one of those things we look for as an intangible reward as we enter the profession. We go through and really dedicate the decade of our 20s to becoming the kind of people who have the knowledge and skills to take control in any situation. And that's a reward we're expecting, but oftentimes we don't get that this day and age in the way that medicine is practiced. There's other rewards as well, professional recognition and collegiality. You know, doctors and nurses, we're great people, but we rarely get the opportunity to connect as well as we would like with each other. And so breakdown of community actually has been identified by Maslow as the fourth driver of a burnout. When we're disconnected from each other and we're really struggling as it is, we start to wonder if we're being treated fairly. Absence of fairness is the fifth driver of burnout. This is becoming even more important these days as the workforce is changing. The demographics of the workforce are changing. And this is a little more challenging for me to speak about. I'm an older white gentleman. I jokingly call myself a pale, stale male. I'm in a situation where it's rare that my credibility has ever been challenged because of things I have no control over, like my gender, my race, or my country of origin. But so many people in the workforce these days actually deal with those challenges on a daily basis. And so in absence of fairness, work on DEI has become more and more important through all of this. Ultimately, the sixth driver of burnout is conflicting values. If my personal values don't really align with the values of the organization in which I work, I really struggle. Now, what Maslow also helped identify was these six drivers actually specifically drive the manifestations. And the first of these is work overload driving emotional exhaustion. And most people, when they think about burnout, that's what they think is going on. I'm overloaded and I'm exhausted. And that's really all there is to burnout. That's a lot of what burnout is. And there's great opportunity to address this by redesigning workflows so we do make a change. We can remove a lot of that administrative data entry and other burden and create the opportunities for work-life balance. So when work ends at the end of the day, that actually work ends at the end of the day, and we can have a personal life outside of work. And while we're at work, as we can reduce the distractions, we create more time and capacity for that meaningful work of connecting to patients, connecting to learners, doing things like procedures and research, because we have that capacity. By redesigning work, we can truly make a big impact in these areas. The other thing most people don't really understand about burnout is that these other five drivers, control, reward, community, fairness, and values, well, those are the things that drive cynicism. And in fact, these are the things that are also innate in the management system and culture. And when we address these properly, we can empower people to fix problems that they encounter on the front lines. And we can align everyone in the organization around what the organization is working towards, how it defines success, ultimately really driving engagement. You know, you may have heard about engagement surveys, people focused on this. How do we improve the engagement of our clinicians, of our staff, everybody across the organization? It's rare to see engagement surveys really identify these five drivers or provide recommendations about how to address them. And yet there's so much opportunity when we do work in this way. Another thought, just to step back, particularly as educators, thinking about some of the more broad issues around just our own professional and personal development. You're probably familiar with Maslow's hierarchy of needs, these steps that one has to go through in order to achieve self-actualization. Maslow's drivers of burnout actually relate fairly closely to these hierarchy of needs of Maslow's, starting with work overload. When we're overloaded, it's a challenge to even take care of our physiologic needs. Probably everyone on this, attending this presentation has had a time in their professional career where they denied the hunger that they were feeling, or they denied their need for sleep, or they even denied their need to use the restroom because work was just so demanding, there was so much to do, there wasn't time to take care of ourselves. When we are out of control, our safety is at risk. When community breaks down, it's hard to experience love and belonging. With absence of fairness and insufficient reward, there's a real challenge around self-esteem. And ultimately, if our values are not aligned, it's very hard to achieve self-actualization. Particularly think of self-actualization as professional fulfillment, that pinnacle of what we're looking for in working truly in congruence in our clinical work. So let's step back a little bit and look about how did burnout happen in healthcare. We've been talking in much more general terms about the 6 drivers of burnout that really apply in any kind of industry. So we'll start, remember, we've got the problem is not the clinician, the problem is the clinical workplace that's very challenging to work in. Why is that so challenging to work in? Well, what's happened over the last 20 years are all of these external forces that have impacted us. Things that in technology with the EHR and other tech things that are developing. The billing and charge and all of the business side of medicine. The changes that have happened with the government and regulations, expectations to achieve great patient satisfaction scores, dealing with things like the opioid crisis, as patient demographics are changing. All of these things have contributed to great challenges that we've had to deal with. And yet, as each of them came in to our world, as long as if we could manage those and still stay connected to what's most meaningful to us, that connection to patients, to doing meaningful things, well, we just sucked it up. We figured it out. We dealt with it. And every one of those we managed through, but we've gotten to the point even pre-pandemic where we really couldn't take any more. We had added the last straw and people were starting to break. And when they broke, we saw injuries, depression, substance abuse, family dysfunction, and suicide. There are still 300 to 400 physician suicides a year in the United States. So this was pre-pandemic. And then along, of course, came coronavirus, and it became COVID all the time, everywhere. It created a VUCA environment. VUCA is a term from combat, which stands for volatility. Things are changing so rapidly, and there's no clarity about the risks that you're dealing with. Things are complex. There's so many variables happening in the environment, and there's no clear right answer. In this situation, it creates tremendous stress. With fear, anxiety, the risk of morbidity and mortality, actually personal existential survival risks, the disruptions to our relationships, financial uncertainty, the moral injury of having to decide how to disperse limited resources, who can get what treatments, are the treatments even right, dealing with challenges of patients, instead of a healing relationship, patients confronting you about whether what you're doing is right, even though they've come to you for your advice. And ultimately leading to PTSD, not just similar to people experiencing combat. This has created an existential threat for healthcare systems, as so many clinicians are now ready to leave the workforce or already have left the workforce. And it's impossible not to hear about this in the news if you read the news at all these days. But this is real. This is a true threat to the organizations within which we work. And with all those threats also comes an opportunity to actually address that, make it better, and come out the other end of this with something that works more effectively. So that's what we'll talk about now for the next bit here is what do you do to deal with this and cope with it? What we recommend is, I call it a 5-step approach. And we'll see, it's not that you can argue whether there's truly 5 steps here or not. But the key issue is that we understand now the basics of burnout, which are in every organization, healthcare and other industries, but each organization, they are unique based on that organization's design, workflows, structure, etc. So every organization has specific unique needs. The approaches to address burnout, you see here this Stanford WellMD model of professional fulfillment that includes enhancing personal resilience, efficiency of practice, and the culture of wellness. Those same concepts are also very common, but to specifically apply these concepts to the specific needs of the organization is really key. It starts with a diagnostic workup, and actually, so the organization I'm part of, O'Brien Group, we're working with Nuvance Health right now, and last summer we went through a diagnostic process of really understanding what's going on in Nuvance Health, what's driving burnout for you, and then have sat down with the leadership of the system to talk about developing a plan that specifically will address the challenges that you're experiencing. And now we are putting into place elements of these 3 opportunities to improve worker well-being, improve workflow efficiency, and improve the management system and culture. As we do that, the workplace, the clinician well-being support really involves developing personal and peer support services and enhancing resilience. That's best done through a Center for Wellbeing and Resilience, and we're in the early stages of talking about that. There's been some efforts for a while now in Nuvance for this, but there's opportunity certainly to enhance that. For the patient care workflow efficiency, reducing that work overload and exhaustion, helping regain work-life balance is key. And that work gets done through redesign work and daily huddles. We'll talk about each of these in the work that we're doing mostly right now in primary care, but the plan is to spread this throughout all of the specialties within the Nuvance Health medical practices. And then lastly, with the management system and culture, reducing cynicism by empowering clinicians to solve problems, giving you back that control, getting some reward and recognition, creating better senses of community, fairness, and alignment. So that everyone is aligned, understands what enterprise-wide success looks like, and we're working collaboratively towards that. That really looks to changes in leadership principles and leadership activities. So let's get into some of these. First, with clinician well-being and support, I think for the role as a clinical educator, the opportunity to be a real role model for learners. When you're burned out, it's tough to be a positive role model when you have no reserves left yourself. So understanding where you're at, how you're feeling, and the impact that you're having on learners who are deciding whether they want to actually stay in this profession, how engaged they want to be. Will they look at clinical medicine and think, you know what, I can't do this. I'm just going to, once I get done with my training, I'm going to go find a tech startup somewhere and do something different? Or am I going to really deeply engage with the patients and find that fulfillment in doing that? You have so much impact on this. You need support so that when you have those tough times, you can get through your day. But don't, and I'm sure you're aware of the impact you have on the learners that you work with. Patient care workflow efficiency, there's so much opportunity to make differences here. We're actually in the process now of redesigning the workflow for a primary care office visit. We had a week-long event a few weeks ago focused on this, and those steps are going to be starting to roll out. And they work on things like optimizing the EHR, improving in-basket management, creating care teams and workflows so that when you walk into an exam room, everything is ready for you and you've got the support you need, and redesigning clinical workspaces that enhance that as well. I'm not going to go into detail on this right now. If you're interested, when we get to the Q&A session part of the talk, I'm happy to talk about this if you'd like. And then lastly, the impact on the culture of medicine, the management and leadership practices. And as a clinical educator, I know pretty much every physician, every clinician is a leader. We work with our staff, we work with patients, we educate and lead them. But there are specific things as you get into, other pure or identified management roles, which can even have more impact. One of the key things as I think about this, is to do it from a very principle-based standpoint. And the first principle I think of is who's the most important person in a healthcare organization. And no question, the most important person in a healthcare organization has to be the patient. Without a patient, we have no reason to have our jobs. The organization has no reason to exist. So the patient is clearly the most important person in the organization. My next question then is, what's the most important thing that happens to that most important person? And that is, in my view, a healing interaction that takes place between everyone who interacts with that patient. Doctors, nurses, receptionists, transportation people in the hospital, EVS people cleaning, lab techs, x-ray techs, anyone who interacts with a patient, with every interaction, there's some opportunity to turn that into a healing interaction. Some way to help reduce some anxiety or worry, relieve some pain or suffering, do a procedure that's meaningful, that's life-changing, or educate people to be healthier. Now, for myself as a family doctor, I've practiced for 25 years. I had close to 100,000 healing interactions. But then in my career, I gradually moved up into higher levels of leadership. I moved up to those levels because I got frustrated when things didn't go well in my office. I spoke up, I got put on a committee, then I became a medical director. Ultimately, I became CEO of a 300 physician group. So I was this person down here at the bottom. You know, I was no longer seeing patients. I think I can get a little, here we go, laser point. So I was here, I was no longer seeing patients when I was doing this role. And so I was no longer doing the most important thing for the most important person in my organization at that point. And it became, and my job changed. It changed from one of taking direct care of patients to supporting the people who reported to me so that they could then in turn make sure that the people on the front lines had what they needed so they could do their jobs most effectively. And a leader's role is so crucial because it sets the tone for the whole organization and it can't be delegated to other people. In fact, Mayo Clinic has done studies that showed that as they score leaders based on a leadership survey, the better that leader scores, the less burnout there is in the organization. Leadership development programs are key. This is actually a leadership development program that you're in here. That's why it's so highly valuable and important. Being seen and heard as a leader is also very important. You can't, when leaders spend their time sitting with committees in conference rooms, people don't really know what's going on. And one of the things we're working on is to help improve the connection between the top leaders in New Advance Health and front lines. There's, you know, people are, I haven't yet met a leader who doesn't want to be connected to the front lines. There's so much challenge though in the demands on their time to get out there, as well as the, you know, figuring out for yourself if all of a sudden some, you know, top level leader shows up in your clinical space, how you would react to that. What does that mean when you see them walking down the hall? So it's important to create a way that actually works effectively, that when a leader shows up, you know why they're there. I spent a lot of time as a CEO when I was no longer seeing patients. I was shadowing the clinicians who were seeing patients. You know, it's important to be connected as a leader. I was worried when I first stopped seeing patients. People would think, well, you know, he's gone over to the dark side. He's just a suit. He doesn't know about my struggles with working with Cerner and what that's like, or my staffing challenges. So I really made an intent effort to shadow the clinicians because in my role, in my job as a family doc, I had certainly the pain I felt, but I didn't know that, you know, the pain is different. The challenge for an orthopedist or an ophthalmologist, a pediatrician, OBGYN, they're all a little different. There's other challenges, and the more a leader can be aware of those specific challenges, the better. And then attending huddles as a coach and a mentor, not to come with answers, but to help people become better problem solvers themselves. And in fact, we'll talk just briefly about huddles because these are some of the most effective things that can truly make a difference. And this is actually one of the initial initiatives that we're rolling out across New Advance Health. Huddles are happening now in about, I believe, 10 or maybe 14 locations. And the plan is to roll them out into every office that's part of the New Advance Health medical practices over the course of the next 6 months or so. And a well-run huddle should last 15 minutes. It shouldn't, and we can't go longer than that because it's going to impact the schedule for the rest of the day. They should be held standing up at a visual management board where people are actively engaged. They include starting out with acknowledgement and appreciation. Who did something yesterday that actually made a difference and made everybody else's day better? That's that, remember the insufficient reward driver of burnout. We want to make sure that people get good acknowledgement. Preparing for the day. Do we have the capacity to meet the demand? What does the schedule look like or the census look like compared to our staffing, compared to the supplies we've got, the equipment, and if it's working? Knowing that ahead of time helps us so that we're not surprised in the middle of the day as much if things go wrong. We can be prepared for contingencies if things aren't good at the start of the day. Solving problems, fixing, I call these little problems, pebbles in your shoe, things that go wrong that aren't enough to stop the entire day, but make you frustrated and think, I'm never going to let that happen again. If you go to the printer and it's out of paper, you open a drawer and what you need for supplies isn't there. When those things happen, bringing them to the huddle board and having the team then decide, is this something we want to work on and fix? And if so, who's going to do that and come back to us in a week with a solution? Every time you take a little pebble out of your shoe, the day goes better, the job gets easier, and you have control over the work that you're doing. Again, addressing one of those drivers of burnout. You work together as a team on that, so you create better community and collegiality. and things start to feel more fair when things are working more effectively. And then metric performance. What are the metrics that the system overall is working towards? And all health systems work towards the same things around quality, safety, access, patient satisfaction, staff fulfillment, and financial performance. There are things that we do at the front lines that actually drive the system results. So understanding what we want to focus on in our clinic that's going to make a difference, and looking at that on a regular basis, not every metric every day, but in a way that helps us make sure we're tracking and makes a world of difference. So if you've already participated in Huddles, I'd love to hear what your thoughts are on them. If you haven't yet, certainly, and they're coming to your clinic, be aware of that, because there can be real value there. So that really covers the high-level ideas I wanted to talk about today. And what I'd love to do now is just open it up for conversation. Thinking about the clinical educator role in improving professional well-being for learners and for your colleagues. What has this stimulated any thoughts for you? Has it stimulated any questions for you? I'd love to just get your feedback about what thoughts these has engendered and how I might actually present them more effectively as well.
Thank you so much, Paul. You covered a ton of material really, really quickly for us, and you left us with plenty of time for conversation. I love it. I'd love to hear the questions or any questions from folks who've tuned in, rather.
I have a question or a comment, as you say. Dr. Mendez, I'm a pulmonary critical care, Paul, and I don't know if you remember, but I was part of the work that you guys did initially with the Wiki Wisdom.
Oh, yes.
The data, so I'm quite familiar with this. I appreciate your presentation. It was a great presentation, and I work with Mayo Clinic too in burnout, so it's not something I'm familiar. But the comment that I will make, Paul, is what do you think about one of the struggles that I have with this is that basically I'm worried about the use of the term burnout itself as opposed to using the word moral injury, which the problem that I have with burnout is that it basically tells me it's my fault, right? It's the provider's fault. And in reality, as you know, it's not our issue. It's not our problem. It's the organization issue. So I'm wondering what your thoughts are about using burnout versus moral injury.
Yeah, well, thank you for that question. It's really an important one, and it's one that gets discussed a lot these days. Moral injury is definitely a component of burnout and one of the drivers of burnout. But it's not the only driver of burnout. And that's part of my concern with using that, completely substituting moral injury for burnout as the terminology. You're absolutely right. Burnout is the manifestation in an individual of a system dysfunction. It's not the person's fault that they're experiencing burnout, but it's the system's fault that burnout exists. Similarly, really, moral injury is not the person's, that's something that's been done to someone. One of my concerns with the term moral injury is that it can lead potentially to a victim mentality, kind of the way that the term burnout can also do that. Moral injury is serious. There's no question between and from multiple standpoints. Even in the most healthy organizational culture, the experience of the pandemic for the last 2 years has placed moral injury would be unavoidable even in a super healthy organizational culture because of the challenges that COVID has created, and particularly for you all that are working in intensive care settings. Ultimately the key is to recognize whatever the drivers are, and then address those effectively. I'd love to actually explore this a little more, because There's multiple drivers of moral injury. There are the things that are in an organizational culture, bullying, unfairness, different things like that. But there are also just the clinical medicine aspects of moral injury. The key is that clinicians and leaders work together to identify those drivers and mitigate them as much as possible. But I'm going to stop talking. I'd love to hear more of your thoughts in response to what I said.
No, I agree with you, Paul. I think the question is really, I mean, obviously the organization is going to do everything possible to get rid of the pebbles, or like, the Mayo Clinic used to say, in the way, kind of get, make it easier for us to practice. But I'm also wondering about the human impact of this and how providers can sort of shield ourselves, kind of thing. So have like a protection and measures that are actually more intrinsic to each one of us as human beings to prevent us from falling into that again, regardless of where we work, because organizations are always going to be imperfect, and there will be always issues everywhere we go, right? And I think I just wondered if there is some more work to do, or in terms of prevention and at the personal level rather than the institutional level.
Yeah. So again, great point. The in the three components of Stanford's professional fulfillment model, there's personal resilience, workflow efficiency, and culture of wellness, or I think of it as a management system and culture. The personal resilience is that way that you can actually strengthen yourself to withstand whatever's happening in the environment with workflow and with culture. When I first, it was back in 2014, I'd been CEO of this medical group for 5 years, led them through a whole process of what I just described. And actually, we had great results. We got recognized as the top performing out of 170 groups in the state of California 2 years in a row. And we moved our physician satisfaction from the 45th up to the 87th percentile on the AMGA provider satisfaction survey, the same survey we used last summer there. But then I left, and I really got into consulting and advising systems on how to do this. And as I attended the burnout conferences, there's a conference on physician health, international or American. Back in 2014, when I first started doing this, it was all about enhancing personal resilience. Everybody at the conference was talking about how you can take better care of yourself. How do you, yoga, mindfulness, meditation, etc. And those were important. And at that time, we really hadn't identified or hadn't gotten leaders engaged in realizing, we're creating some of this problem. We need to help address it. So that I've been gratified to see the work move away from a sole emphasis on personal resilience to addressing workflows, and now even really recognizing management culture. That said, there's so much value in taking care of yourself and doing that personal resilience work. And it's been demonstrated that people who do are able to engage in taking care of themselves, yoga, meditation, mindfulness. They themselves are personally healthier. Their patients have better outcomes. So it's not been to dismiss this at all. And creating that capacity, having the system recognize the importance of it and supporting that is really important also. I know that that's one of the areas that leadership at Nuvance Health is focused on. We're really just now in the process of further identifying all of how all three components of this approach will really get fleshed out.
Thank you.
Paul, I was wondering, healthcare is insane as it can get. And it gets more insane with each and every day. And these drivers, exhaustion, depersonalization, and inefficiencies just seem we're immersed in it. Is this uniquely healthcare, or have you seen those similar drivers in other industries? And if so, what are they doing to address this in their industry?
Yeah, another great question. So yes, this is not unique only to healthcare. Certainly a lot of the specifics about what the drivers are unique to healthcare. But again, one of the people I've really gotten to know well in my work over the last 7 years is Christina Maslow, who wrote the Maslow Burnout Inventory and has written many books on it. These drivers that she identified, actually, she identified them 30 years ago. So it's not that they just got identified recently with healthcare. They just apply to all industries. One of the big ones that she sees this in is the tech industry. And in fact, it's a completely different mindset than healthcare. You know, people are out to create the next killer app, you know, have a great big, you know, make a lot of money on an IPO or a buyout or something like that. There's not as much mission-driven work in a lot of, and certainly in tech, and so there she sees this as a real challenge where it's the question of what is that core culture of that industry itself. There are some tech companies which do have a healthier culture, others that don't. But it's true in every industry. In fact, one of the other examples I like to talk about is this gentleman, Bob Chapman. Bob is a CEO of a company makes heavy industrial equipment. They're based in St. Louis, so they make things like bottle washers for Budweiser and stuff like that. And you wouldn't think that this would be a particularly enlightened place to work, but he's actually grown his business well to have 80 plants in 17 countries around the world, do like $3 billion a year of revenues. And he was a pretty traditional CEO till one day he had an insight thinking, what would happen if I treated my employees with the same care and concern I treat my family and my close friends? And actually put those principles into place in his office, in his main office in St. Louis, and then used Lean as a management system and culture to spread those across the world and wherever he was located. And it's been transformative for his people. So when I first saw him present at a conference, which was a conference about Lean, I joined a Lean consulting firm. They sent me to this conference. I thought, what am I going to learn at this conference? These people make garage doors and widgets. You know, I'm in healthcare. We're noble. Why should we, you know, what am I going to learn from these people? And yet what happened was he presented with a panel of 5 other CEOs who had this approach of caring deeply for their people. And I left embarrassed for healthcare because I realized in so many ways we treat we're noble and care deeply for patients, but quite often we're very harsh on each other. And what he was able to do at Barry Waymiller, this company that he runs, has become an example for others as well. It's still a very small percentage in any industry of companies that are doing this work, but I see hope. Although every time I start to get hopeful, I also see people who become very greedy and diminish those hopes. But there are organizations out there that get this, that are working towards it. Ultimately, those are the ones that really do well. I mean, Barry Waymiller, Bob's corporation, it outperforms Warren Buffett and Berkshire Hathaway on return on equity. So this is a great business strategy actually as well, particularly in the days of the Great Resignation. If we can work in a place that values us, we're not going to leave, and we'll tell our friends to come work here as well. In fact, one of the things that's already happened in these offices where we've implemented the huddles is that there haven't been, since every office where once the huddle's been implemented, there has not been staff turnover in those offices, which is a big change from the way things had been before, because one of the big challenges at Nuvance, like many health systems, is this level of turnover. And we're starting to see that already decrease, which is really heartening.
It's great. Thank you.
Sure. Any other questions? I think maybe.
I was going to ask a quick question. I'm curious if you could speak a little bit more about the Center for Wellbeing and Resilience. I think you mentioned that's something that may still be a project that's underway, but maybe you could share a little bit about the vision for that, or if it is a model that has been implemented in other organizations. I would love to learn what that might look like.
Yeah, actually, it is a model that's been in many organizations, including those in and around, Connecticut, New York area. There's many of the organizations start with a chief wellness officer as someone who kind of leads that effort. And so, not necessarily name names that are direct competition, but Hartford Healthcare, Yale, New Haven, Down in the city, Mount Sinai, others have chief wellness officers, some of whom have become, I know personally, and have become pretty prominent in the national discussion as well. Working with the leadership there, this is something that definitely it's on the table. We're working towards. We want to do it right. We don't want to just, slap it together in a way that's not going to be effective. We also don't want to wait too long to get it started. And there have been efforts, certainly within the HR department. There's a well-being committee already that's a general well-being committee across the entire organization that's we're connected with as well. There are some things that are unique for physicians, particularly peer support efforts have been a very strong component of many health systems' well-being efforts for physicians, because people, people in a specific role understand each other better. It's true for nursing as well. Peer support for nurses as well as for physicians has been very helpful and effective. And there's ways to set that up where there's formal support for it, where people start to get connected, where you know who that person is that's there for your support. You can build this into orientation to get started, as well as build it into departments that are active and running. Finding ways to provide support, particularly when you've gone through some of the challenges you've gone through where it's hard to take care of yourself. Can the system help support some of that? And there's been some work around, gosh, I'm working so hard, I don't even have time to prepare a meal for myself or my family. Can we deliver some food? When somebody really needs help, they've just had it, is there somebody you can call to count on? Are there confidential places you can find someone you can talk to confidentially without fear of becoming exposed? There's so much fear and stigma associated these days with admitting weakness. And I think actually the pandemic has helped a little bit to help reduce some of that, and that everybody recognizes what we've been through is something, no human being really can do all on their own and remain completely intact. So the stigma of saying I'm burned out is not what it used to be, but it's still there. There's still this fear that, people might think less of me. And so finding confidential ways where you've got a source you can go to is important, particularly because there are still a lot of people who are very stressed, and getting that help can make a difference. So peer support, getting through your day, I kind of call them activities of daily living for clinicians, just, or confidential places where you can talk to somebody who can help you without your fear of being identified or stigmatized. These are some key components of that work.
Thank you so much.
Are there other comments or questions?
One of the things, if there are, please feel free to just jump in if you've got one, and I'll just sort of add one or two other comments here as we talk about it. What it can often, a lot of what we focus on are things that you may feel as though you don't have that much impact on. It's certainly taking care of yourself is something that you think, well, I'm the only person who can take care of myself. I could get some support for it, but that's really my responsibility. And yet that's the thing that's not addressing the root cause drivers. It's not, it's not getting to the cause of the pathology, so to speak. Fixing the workplace, workflows can be a challenge, and you can feel like, well, that's somebody else is doing that. That's not really my job. This is where getting involved in the huddles can truly start to make a difference. And it doesn't require that much investment of any one individual. The huddles are led by the office manager. They bring everybody together, looking for your recommendations, thoughts, and ideas about how to make things better, identifying what your frustrations are. When huddles come to your location, I really encourage you to, while it's natural to be uncertain about something that you haven't experienced yet, this is so valuable and important to get engaged in. So I really encourage people to get engaged when the huddles come to you. There's been, in fact, some people have heard so much about them. They said, well, let's just do them ourselves. Let's get started. We see these boards. Can't we just order some boards, put them up in our offices, and let's just start doing them? And there is a a process to it that makes it truly effective. And without that process, quite often these huddles can fall apart and not be of value. So, thinking about, can you identify problems and start solving little ones with your team? Sure, I would never discourage that. But for the huddle for that office or for a unit, waiting until it's come to you and you've got the basic training in it and support to get started really is valuable. But definitely engage in it. And if you see simple ways to start solving problems, there are some pretty straightforward ways. I'd never discourage that. And then from a leadership standpoint, connecting higher level leaders with frontline people is really key. And that's a challenge for both parties involved. One of the things I often get asked at the end of a talk is, well, what's one thing we can do next week? We know this is a big problem. There's lots of challenges. What's one thing we can do next week? And I usually say, if you're a leader, go shadow clinicians while they're working so you can truly understand the challenge. But if you're a clinician, invite a leader to come and shadow you. That may feel a little bit more, out of sorts, but if you've got, it doesn't have to be John Murphy. It could be, you're the manager of your unit or office. To say, hey, you want to see what it's really like? Come follow me around for an hour or something like that. Ways to just get the conversation started that can help to make a difference. So that might be ways, as you're feeling like I'm kind of I'm that person who's doing the most important thing at the front line, but I'm not necessarily that empowered. You could take small steps like that, fixing little things or inviting somebody who is in a higher level of power to come and see what it's all about.
Other comments or questions? Paul, I just wanted to maybe emphasize and ask you to elaborate a little bit more, if you would. Many of us in healthcare feel like we're just kind of get it done people. We solve problems, we face challenges, and for folks who have that self-image, including myself, admitting that I can't do it all with everything remaining perfect, admitting that there might be an element of burnout is challenging and conflicts with self-image. How unique or not unique are those of us in healthcare in that regard? And how do you think about that and help to mitigate?
So unique in healthcare as opposed to other industries, you mean? Yeah. I think it really gets down to what perhaps this concept of knowledge workers, because there's, as industries get and technology gets more and more advanced, more and more people are doing knowledge work, and you can define knowledge work as knowledge worker is somebody who does a job that their manager doesn't know how to do. If you're on an assembly line and your boss tells you, knows what you're doing, they came up on that assembly line, they can tell you what to do. That's one thing. But when you're doing a job that the person who's managing you can't do, they don't understand it, they haven't done it, that's a completely different thing. You have to lead in a different way. And even for myself, when I was CEO of a family, I was a family doctor. Certainly I didn't know the job the neurosurgeon did. There's no way I could tell the neurosurgeon how to do their job. So it's a matter of really listening and understanding and collaborating between highly skilled knowledge workers and the people that are supporting them to get the job done. And that gets into things like understanding, really being sure, and especially when you love to solve problems quickly and easily. One of the challenges with solving problems that cause burnout, particularly for doctors, is we have become these people who can walk in a room and know what to do and do it immediately. And the reason we can do that is because we've done it tens of thousands of times. And so we walk into a problem and we think, well, I know what the problem is with this, things are hooked up wrong, this isn't there, who is the idiot who put this machine in this spot in this room? I've had those thoughts many times. We come from that mindset of rapidly solving problems, and we really enjoy that. We dig it. It gives us satisfaction. We release dopamine doing that. But But in fact, these problems are complex, as are many of the problems with our patients. But when we, and our knowledge base and experience is such, we can solve those patient problems quickly. But if you stop and realize we're dealing with something different now, something we haven't done before, solve a situational organizational design problem. And yet the first time that we took care of a patient, that we assessed a patient, that we made a decision about a patient, third year medical school, you're going through your clinical education rotation, and your preceptor says, go ahead, go see this patient, work them up, tell me what you think's going on, give me your recommendations about what to do. It took hours, and I got it wrong. It's not something we knew how to do naturally. The whole point of that education was to go through all of that training. And yet and so we could make those decisions quickly, but we tend to take that same mindset to solving these system and workflow problems. And so we come up with a quick solution without realizing there's a whole bunch of other stakeholders involved in here. Just like, there's a whole, maybe the lungs are messed up, but it's impacting every other organ system. There's a whole bunch of others. There's the nurses, there's the frontline staff, there's supply chain people, you name it, that are involved in the complexity of solving this problem. If we don't engage all of the stakeholders, understand the whole ecosystem in which we're working, we have a great solution, but it's probably not taking into account all the other variables. And so when we step back and get engaged with a team that brings those other variables and stakeholders together, then we can truly make a difference. And I've seen this happen. I certainly had to learn that lesson myself, and I've seen it happen over and over again. When I was, as we were redesigning the call center at Sutter Gould, where I was the CEO, one of a great guy was a chairman of the Department of Surgery, said, I want to be on the team that works on that call center because I know I've got the solution, and I'm going to come in and bring that solution and help everybody understand that I'm right and that we'll do it. And by the end of the week of the redesign planning, he came out of it and said, man, I'm sure glad we didn't put my solution into place. I had to listen to everybody else, realize everything else that was going on, and we all collectively came out with a much better solution. But it's that mentality of, we learn over time to solve these more complex system problems more quickly as well. But to get started, we have to step away from that mindset. And leaders have to recognize we're leading, we're helping support knowledge workers. So we also have to listen to the knowledge workers. They really know what the issues are. If we ignore those, then that's not going to work either.
Thank you so much.
Sure.
We have just a few minutes left in the hour if there's any last thoughts or comments.
Now I'm just going to share my screen one last time I don't think, there we go. So this is my wrap-up slide here, which just says that our goal is to have this healthy workforce. In fact, one of the docs we worked with in a different system in Georgia said he didn't know, he was 35 years old, said, I don't know how long I could continue to work. I didn't have a life. But after going through this type of work, now I've got time for myself, I've got time for my family. I can practice for another 20 or 30 years. So that's really where we're going with all of this. And if anyone is interested in connecting with me more, actually, I'm happy to send you a signed copy of my book if you email me at that email address there. I'm happy to do that. And other ways you want to follow up, I'm always interested in learning what's happening to people on the front lines and what I can do to help. So feel free to reach out to me in that way.
Completely amazing. Thank you so much, Paul. And I will attest that, Paul, your blog is really wonderful to follow. And thank you for the copy of the book you provided me. I know your offer is sincere.
Thank you, Robin.
Amazing. I'm going to wrap us up. Thank you to all who joined. The conversation was really robust. I know we have a lot more thinking and talking to do, but Paul, thank you so much for getting us started.
Oh, my pleasure. My pleasure.
Right. Everyone be well.
Thank you.
Take care. Bye, everyone. Thanks.